Dear audience, dear committee, I would like to present my PhD topic entitled Dental Prevention Procedures in Childhood and Children with Special Needs. But first, let me give you a quick interpretation about myself. I'm Dalma Tábi, and currently I'm working at the Department of Community Dentistry. I'm a first-year orthodontic resident, and I vision as a PhD student that most of the children with disabilities can attend to a specialized preventive program. So our mission is to develop this program which meets their needs. You can see here my two ongoing projects. The first one is assessing the effectiveness of dental prevention programs among children. They are healthy children, and this is a systematic review and a meta-analysis. And the second one is a pilot study for an RCT, school-based prevention program for special needs children. As we all know, bad oral hygiene is a major public health problem, and it affects not just the individuals like children, but the governments as well. So oral health education is an important tool to improve the children's oral health knowledge. So the aim of this meta-analysis is to find the most effective method. So we included studies with children between the age 5 and 21 who attended school, and the intervention group received school-based oral health education, and they had a control group who did not receive the education during the follow-up period, and as an outcome they measured the changes in their oral health. The primary outcome was the DMFT values, and the secondary outcomes was more or less plaque indices. And we are hypothesizing that children receiving this education will have better oral health indices after the education. You can see here my systematic search, and to be honest, this is my second search because I submitted this paper during the winter, but it was rejected, and they said that I have to redo the search because it's outdated. So it was run in the beginning of May, and the search key had two main domains: the population, the intervention, and some specific terms for this education. And now we are working on the full text selection. We already have from the first search 27 articles, but probably I will have 3 or 4 more to include in this analysis. So I will show you the first version of the plot. As a first outcome, we investigated the changes in the DMFT indices. You should know that the DMFT refers to the number of teeth which are either decayed, missing, or filled. And as the World Health Organization suggests, you should measure these values in every 5 to 6 years to see significant changes. And that's why this is one of the reasons we could not see real significant changes or clinically relevant changes, because most of the studies have only 3 years maximum as a follow-up period. Usually they have 6 months, maybe a year, sometimes more than a year. So most of the studies has DMFT as their primary outcome, but in this way we could not really analyze it or see the significant changes we would like to. So our secondary outcome is the changes in the oral hygiene index simplified. Oral hygiene index simplified can be measured from 0 to 6, and the higher the value, the poorer the person's oral hygiene, because it contains 2 domains: the amount of debris on the tooth surface and the amount of calculus on the tooth surface. And here we could make 3 subgroups based on the provider of the education. The first one was the healthcare worker, so somebody who is health-related, like a dentist, dental student, school nurse, provided the education for the students. In the second subgroup is another category when they watched video for the education. And the third one is a teacher-led group, when a teacher provided the oral health education after they received an education how to interpret the knowledge. And here we could see clinically significant and also mathematically significant changes in the healthcare worker-led and teacher-led groups. Here you can see the changes of the oral hygiene index simplified during the follow-up period, and we can see that at the beginning the index was quite high, but almost the same for the two groups. After the education, there is a significant change in the intervention group, so the oral hygiene become better, but after several months, it was 6 months, the index or the values increased again. And this is a strong message that only one time for this education is not enough. We have to repeat with the children, so maintaining a good oral hygiene becomes a habit, not just an act for a short period of time. So we have our strengths that we use just RCTs, we included different educators and various indicators, but of course the limitations is the heterogeneity because of the education, because of the children, because of the follow-up period. We had difficulties comparing the intervention and of course the short follow-up period. Our conclusion is the education in short term is effective, so we can use it, but we really have to make a policy who teaches the children and which way and the amount of repetition they need. So unfortunately it was rejected from the International Journal of Pediatric Dentistry, but they wrote in the letter that they would consider to accept it as I correct the mistakes the three reviewer wrote in the rejection letter. So now we are rerunning the search. And some words about my second project, that in Hungary, almost 7,000 children under 19-year-old somehow would have some form of disabilities, and there are no prevention programs, no education for the dentist, so they have higher DMFT values and higher unmet dental treatment need in this group. So we created an education program for the children and the András Pető Institute who received this prevention program, and in the study we would like to have a control group while investigating their improvement in the oral health indices. We include as many children as we can. The only exclusion criteria that the children who are not able to cooperate the program due to intellectual disability. Here I try to illustrate the upcoming RCT's group allocation. It's a little bit complicated because to maintain the ethicality of the study, so all of the children can benefit from the education, it's quite a round system. So the first group with the yellow line is a control group, and the second group receiving the education for 8 weeks. Then there is a washout period with the red line, and after it they exit the study, and the control group becomes the new intervention group. So in this way, all of the groups receiving the study, we can record almost all of the children's data, and they can benefit from the education. Here are the preliminary results of the pilot study. We can see that there were a significant change in the oral hygiene score between the first week and the 8th week. So after the education, the oral hygiene index decreased, and after the washout period, so the second 8th week, there was a little bit increment, but it was not significant. And currently, I'm working with this manuscript. It's under revision with my supervisor, but we are trying to submit both of them in this month. My additional activities that I have presented, my meta-analysis is the Semmelweis Symposium, and I'm going to present the EADPH conference at Crete in October. And I would like to thank you for your attention with a quote from Grey's Anatomy: "You have to go back to the beginning to understand the end." Thank you.
Thank you for a nice presentation again. And questions?
So thank you for the presentation. My question is about the groups. How did you choose the number of children you put into a group?
Thank you very much. So we had 8 children. We had 2 pilot groups, and we had 8 children each of one. We started with the number of 5 with my colleagues that, okay, we can deal with 5 children at once. But after all of the children received the form that they can attend this program, it was 97 children at this time. Only 20 received the consent form. So after the selection that who can we include and who can we exclude, there were only 18 children left, and no, 16, sorry, and we divided them into 2 groups. So that's why we had this low number of children. But next, we try to organize this education, not just an extracurricular activity as it was, but must have during their school period. So we try to implement it, their science lesson, for example. Thank you.
Thank you for your excellent presentation. I have 2 questions regarding your pilot study. So, is there any evaluation system for the physical impairment of the disabled children? And if there is, then based on that, did you or have you planned do some subgroup analysis?
Thank you for your question. Yes, they have. They mostly use the GMFCS scale, so the growth motor function scale, and it's a scale from 1 to 5. Who received the 1 mark, he can run, he can step on the stairs, for example, but who is receiving the 5 value, probably he's in a wheelchair, he needs assistance. So yeah, we use that scale, and they use it in the school as well, but they didn't differentiate during the educational part, and it was easier for the pilot study that we included all the children with different indices, but after the program, our conclusion is that we need to differentiate them because they have so different skills, not just intellectual skills, but the motor skills that we have to differentiate them according to their level of mobility. Thank you.
I just would like to congratulate your work, and I really respect that you are doing this, and I really appreciate it that somebody does this work for these children. I have just a very simple question that regarding the pilot study, that what are you doing during the control period? You are just watching the children and doesn't say anything about oral hygiene, or what?
Yeah, we exactly do this. No, we went to the school because we are going there every 2 weeks, and we just saying hello and okay and how are you, but we don't really ask about their habits, their how it is going, do you brush your teeth, do you remember? So yeah, we are just completely leaving them for maintaining their oral hygiene practice and what they learned. After it, our experience is that we need to repeat this education once in a year. It's my little secret, but we have the 1-year follow-up data, but it's not ready to present, and that's our conclusion that yeah, that 8-week when we leave them alone is great, but we have to make some reinforcement for them.
Do they know at least you are dentist?
Yeah,
I
they
suppose,
know.
yeah.
Yeah.
So I think these kind of, I don't know, but these kind of children, they are so appreciated that somebody just dealing with that, just telling their story or whatsoever. Maybe this is a placebo effect. Even they don't, if you don't speak about oral hygiene, they have some improvement.
Yes, they are know that we are dentists, and it can be a risk of bias that we are meeting them. So in the big RCT, we won't meet them during this period, and they won't see us. So we're trying to eliminate this, to
Thank
remember them that I'm here and I'm watching you.
Thank you very much.
Thank you.
Thank you. Very nice. Thank you. Congratulations. I have a few ideas. First, say, I'm a bit skeptical about this DMFT outcome, like decayed, missing, filled tooth. I mean, do I expect that to change if it's not a transition from milk teeth to remaining teeth? So age is, so how do you interpret? Because if it's a filled teeth, I mean, what does education change the number of filled? So what's your opinion, and could you convince me that it's an appropriate measure?
It's a really nice question. The MFT is a tricky one because here we could measure it, the real DMFT, because we only observed the adult teeth for the children, not just the baby teeth. So we excluded the baby teeth and just the adult teeth. That's the first point. So we can see the DMFT in real time. Because with baby teeth, you don't observe or investigate the missing part because it's a baby teeth, you can lose it. And the second part, it's tricky because the DMFT can't really decrease. Once you have a tooth which are decayed, it either become filled or missing. So that's why we did this. Honestly, we did this analysis, but it's not my favorite because of this part. So it would be better to see in a long follow-up period the tendency. So the tendency of the changing, that okay, from your first 10 years, I lost 2 of my teeth and I have 10 decayed teeth, but after 10 years of education, I have all my teeth filled without cavities, without missingness. So yeah, that would be better to see the parts of the DMFT separately, but we was not as fortunate to have this data from the articles.
Okay, thank you. My other thought is that, like, you made subgroups based on whether it was a healthcare worker or a teacher who gave the education. Did the studies consider like the form of education, like the boring, here's this like prosthesis and you have to wash it like this, or like some cartoon or something, and the parental background, like the family background, because usually it should come from the parents themselves to brush your teeth. Thank you.
Yeah, so the subgroups, it was hard to decide on the subgroups because there were so many types of education. So I can't even name 2 articles which were exactly the same, high heterogeneity, yeah. So that's why we choose these 3 subgroups to somehow compare them. And mostly I decided that based on the description of the education, that was another risk of bias during the study. I selected the boring teaching parts for the teacher and the dental students or the healthcare workers, because if they used some, first the other group was named fancy group, so if they used some fancy educational tool like videos, short drama acts, mobile apps, that was the other group. So that's how we tried to decide. And yeah, the parental education is another topic. we try to include it, or I'm thinking about a network meta, because they usually used parental education as a form of education and see the effect of on the children, but they didn't compare it. Control group, we choose first one, so maybe my next topic will be a network meta from it.
Thank you. Can I have one more question? Sorry if I missed, what kind of education do you use? Like films or like the boring stuff?
No, we try to not do the boring stuff. It's a live presentation, of course, but our education lasts for an hour, and we try to do it really interactive. So yeah, there is a presentation with plots, but for example, we used some educational material, some games, Kahoot, for example, for the children. They are really competitive. So it was a great win, and we try to do it not as boring, and they are really excited before every class, so I think we achieved this.
Thank you very much.
Thank you.
Excuse my ignorance, but your oral hygiene index, which is better, if it is high or low?
Low.
Low is better.
Yeah, the
Oh, that's
higher
okay.
the index, the worse the personal oral
that's-
hygiene.
Oh, I'm settled now. Okay, thank you.
Yeah.
I'm relieved. Thank you.
Yeah, it's about the amount of tooth surface. So if you got a 0, that means that you have a clean tooth surface, and for 1, 2, or 3, it's the surface, depending on how much debris do you have.
Thank you. I just wonder, is there any study which is dealing with the education of the parents only, not the child, and see what happens with the kids if you are giving an education for the parents for a couple of times?
There are studies, but they usually investigate really little children. So from the infant age to 3 or 4 years old. So yeah, that's totally different, but they are investigating the effectiveness of a parental education as well. They are interesting.
Okay, just one more last question, then this DMFT, joining back, that those papers definitely dealt with this, right? So how did they conclude with that? Why did they look at it for such a short time? Indeed, you would expect more cavity if it was not, but maybe. Although in kids, it's relatively easy to get cavities if they are not treating their teeth. So what was the conclusion of those papers regarding the NFT?
Honestly, sometimes I don't know. I think it's just the practice they use to that. Okay, we have caries, then we choose the DMFT, our first outcome. I can say that half of the time they mention that, okay, we see that change, there is a good way, but it was really interesting for me as well that we use this index with that short follow-up period. So it's another implication for research as well that we shouldn't use it.